Kentucky Friday afternoon. So we appreciate everybody joining here today. This is our CSA Innovation Network coffee chat. The coffee chat focus today is with Joshua Fowler, who's with Just Roots, Food is Medicine CSA Partnerships. We've had a little bit of chance to go back and forth with Joshua on some of their program that they've been doing there in Massachusetts. And I know you guys are going to be really excited about the kinds of innovations and impacts and work that Joshua's doing there, knowing the kind of work the rest of our group does here in the CSA Innovation Network. And I just want to just a very quick pause before we officially launch into our back and forth conversation. Sadie, you want to just introduce folks a little bit, remind people about the CSA Innovation Network?
Definitely. Thanks, Tim, so much for that brief intro. I'm Sadie with the CSA Innovation Network. I'm our network coordinator. And I actually work up in Madison, Wisconsin with Fair Share CSA Coalition, who in connection with the University of Kentucky and many other organizations nationwide form the CSA Innovation Network. We are a national group of technical assistance providers focused on CSA and small farm support. We also connect with farmers and other types of assistance providers in this space, just in support of increasing the viability and sustainability of community-supported agriculture in various forms. We all know it's evolved over the years, and wellness and health is definitely an aspect of CSA that we're really excited to be able to dig into. I will drop a couple of links into the chat for you to be able to look up our CSA Innovation Network website, find recordings of our previous ideas labs and coffee chats. We're also recording this one today, so you'll be able to find that afterwards, and many other resources that we share all around CSA. And now, yeah, we'll pass it off to Joshua from Just Roots. So we're really excited to be able to host you today, Joshua.
Thank you so much. I just really appreciate the invitation. The work that we're doing and small farm support and food access doesn't happen in a vacuum, and I really appreciate the opportunity to build coalition with you all. So I work with Just Roots, and we are a land-based food access organization. And over the past, it's about 5 years now, we've really started to work in food as medicine. I think that that's primarily what we're going to be chatting about today. And we started out as a community farm. The town of Greenfield, Massachusetts, clamored out for it. We're out there right below Brattleboro, Vermont, in Franklin County. It's, of course, county in Massachusetts. And we're looking at a lot of rural poverty. I know that Massachusetts doesn't always seem like that from afar, but you know, there's a lot of space between folks, and they don't have transportation. So, yeah, we built ourselves around how to get food out to folks that needed it. And I've got a brief presentation that we give to our Food as Medicine partners. These are primarily accountable care organizations, and these are organizations, healthcare organizations that serve Medicaid and Medicare patients through the 1115 waiver. So that's kind of first and foremost to get out of the way. And without further ado, I'm gonna start.
Yeah. So while Joshua is pulling up that presentation, just to encourage everybody, this is a super informal chat format. So if you've got questions as Joshua's presenting things, we've got a handful of sort of themes that we're going to go through. But if you've got questions you want to drop in the chat, or if you want to click the raise your hand button, we'll certainly be happy to stop and entertain those and go back and forth. So yeah, appreciate everybody being engaged.
All right, so we are on town land. We have a lease with the town of Greenfield. It used to be the poor farm. It has been a vegetable farm for hundreds of years. And we're excited to continue to be there, getting food out to folks that need it. Just Roots started as an organization about 15 years ago. Like I said, we've been working in food as medicine for about the last 5. Now, the way that we got there, very briefly, is we, especially with our lowest income members, we started to recognize that running a sliding scale CSA, offering vouchers and different opportunities for people who are experiencing food insecurity to pay, was having a physical effect on the families who were participating. So we had the opportunity in 2018 to work with Dr. Seth Berkowitz, who helped us to quantify that. And that has been incredible. So, you know, it seems simple, and I know a lot more has been done at the time, but he was just able to show that participation in the CSA increased fruit and vegetable consumption in low-income families who are participating. And that, I tell you, is just catnip for healthcare partners. So soon after that, we started working with Boston Children's Hospital. And after that, Mass General Brigham, Atrius Fallon. So briefly, I'm just going to go over a few things here. And this is not custom made. This is for our healthcare partners. So some of this I'll just skip right over, but you can see how we're explaining to them what we do as well. Social Service Organization is shorthand for our healthcare partners, SSO, excuse me, for the nonprofit service providers that work with them to execute that 1115 waiver flex funding for Medicaid patients. So should say that 1115 waiver on Medicaid has not been adopted universally. We were early adopters here in Massachusetts. It's certainly a bumpy ride, but it has been an excellent tool to get food out to low-income families experiencing food insecurity throughout the Commonwealth. And you know what we do, in addition to providing food CSAs directly, is we make it really clear to our partners, to our participants, that we are land-based and grounded in a local intervention. So our twin goals are creating food access and developing a resilient food shed. This is one of those things that our healthcare partners are really concerned about. That accountable care organizations want to reduce the cost of care. They know that they can do that through housing interventions and nutrition interventions. So they want to see less morbidity, they want to see less emergency room visits, and they want to see increased progress in biometrics. And just that 53 billion annual cost of healthcare, really the effect of food insecurity is the major driver for our ACO partners. It's complicated, right? It's complicated to work with healthcare. We have complex data reporting and HIPAA compliance. We have to really be on top of our administration in order to make sure that we are protecting patient anonymity. We do provide, we have a very wide and diverse participant pool, and we make sure to provide culturally appropriate, bilingual, bicultural casework support to all of our members on call. And the idea as well is, we're not just providing the food, we're also providing cookware, we're providing recipes, we do cooking classes, and like I said, the on-call support, just to make sure that people don't get the box of local food and then not know what to do with it. So we do an awful lot of outreach through a number of different avenues that we can talk about later. And we do an awful lot of surveying too. We do that balance between not surveying too much, not burning people out, but we really want to know and refine our box to make sure that we're offering the most appropriate local boxes of these. And like this says, that says 1 million. I think this year it's about 1.5 million back into local food infrastructure that is not our home farm. This is what they receive. So recently, and again, I said it was a bumpy ride, but CMS just changed the guidance, and we're all celebrating on the maximum amount of time that patients can participate in nutrition intervention. Up until 2 weeks ago, it was 6 months. They've just relaxed that, and so long as their eligibility criteria remain the same, then they can be re-enrolled. We're waiting to hear how that's going to change for us and our ACO partners, but we've certainly found that the kind of dietary change, and our primary targets for our programs are pediatric households. So it serves the whole household, but the referrals are pediatric patients. And it's pediatric patients experiencing food insecurity and with complex diet-related diagnoses. So we're making early contact, excuse me, and that diet change, the trying new foods is critical to change diet habits going forward, but it also takes time. So, in a short intervention, great, but we want people to be enrolled as long as they need to be enrolled. That's the cookware that we send. All of our meats are local and sustainably produced. The pigs are right there on our farm. We get fish caught off the bay. And for us, right now, local looks like we try for 120 miles. So that looks like all of New England plus Western New York, which that Hudson Valley in New York is prime agricultural land as well. I haven't spent much time up here. Excuse me. We also recently received an LFPA, a local food procurement agreement with the USDA. Their requirements for local is 400 miles. So that's like way outside of what we've been doing. But rough year. Oh man, climate change is happening. It's real. We've had 200-year floods in the past 3 years. And I'll talk to you about our farm partners, World Farmers. Man, this year they got wiped out. So we're both growing and aggregating to give us a little bit more resilience, because these are patients that, unlike standard CSA, come hell or high water, we have to produce these boxes. That's what it costs the ACO per patient about. It can be lower, but this is our pitch. So we're looking at a high value ticket here for 6 months intervention. Here's some recent patient testimonials. We try really hard. It's certainly, we have to adapt. We have to listen to what our patients are saying. There's a lot of different experiences. A lot of people don't have transportation, so we deliver door to door. Our interventions year round. So what we do is we do the summer CSA, which is mid-June and October. And we do weekly deliveries then with a monthly delivery of protein at the end. Those protein shares are great. I showed a picture before. But then in the winter months, November through May, we do 2 deliveries, slightly bigger boxes with protein in each, so that people can hunker down, have some party food in those cold months. Feel great about some of our data and have really learned from people like Dr. Berkowitz and Bay State Health on how to capture the data that is most impactful on our constituents. 75% of our participants feeling better overall physically is just a windfall, and our ability to reduce the experience of food insecurity for participants it's why I'm doing it.
So Joshua, can I just quick interjection? We've got several really good questions that are popping up, and I had one myself on that previous slide. It's really interesting that a lot of those measures are kind of qualitative, self-reported by your participants, your shareholders.
That's right.
And do you find that compelling to the partners, wellness partners that you're working with find that compelling?
Yeah, absolutely, they do. And really what they what they are looking for is, they love to see the metrics. And our survey design is not happening in an academic setting. So, first and foremost, it's absolutely worth calling that out. We have done academic research, but at the moment, it's just, we do these at least 3 times a year and want to continue to have that finger on the pulse. What our healthcare partners really love is the qualitative testimonials. So
Yeah.
if we can capture testimonials that say, I'm a mother of 5, and if I didn't receive the program, my children would be, eating pasta most nights. It's exactly what they want to be seeing. So we try to balance it. We would love to continue to do academic research if the opportunity arises, but I know that there's a lot of amazing organizations like your own that are doing that as well, and we just try to ride on tailwinds, as it were.
Yeah, you put that other slide up there too. A good question came up about per patient cost. So maybe explain that just a little bit more for us. Is that what costs are you capturing in that?
Yeah,
And is that
so
the 6 months, 12 months? What are we? Help us understand that.
Absolutely. So that's a 6-month intervention. So that's either weekly or bi-weekly shares with plus the protein, as I mentioned. And these are typical farm shares. You're looking at a $40 or $50 box. And on top of that, we get the cookware kits, and the cookware kits are valued at about $500. It's everything from knives and cutting boards to slow cookers, immersion blenders. It's basically assuming that you're starting with nothing. And the assumptions can come around and bite you. And so we ask people if they want it, and nobody says no. It's a nice gift. Yeah. In addition to that, it's the care, it's the wraparound services. We do cooking classes, casework. We're available on call. And we take this pretty seriously. We do a lot of mitigation and communication. We're often the first people to know if the patient has moved, or they're experiencing homelessness. There's a lot of transitions that happen in our participants and the participant body, and we can get them resources right away, or refer them back to the community health workers who have sort of a wider palette and more available funding to help us make sure that people's needs are getting met. Yeah,
good. Marilyn, you had a question?
I sure do. Thank you. Joshua, I love your description of your program, and I'm an epidemiologist and researcher from Washington State, working with a local food hub. I'm curious about your nutrition education program. I'm wondering, who designed and developed your curriculum, and who implements and manages that program. I really like the fact that for all of the healthcare entities you're working with, you have sort of a consistent program that everybody kind of getting the same dose, the same intervention, so to speak. So I'm curious about that.
Yeah, absolutely. And so we've worked closely with the local community health center and with our partners to develop appropriate curriculum. And then the survey loop is incredibly important too. So we make sure that the format, the timing, the recipes are appropriate for the participants. And we take it to heart and change our programming based on the need of the patients, and it's the described need. Now, we are not working with registered dietitians, and I should call that out, ASAP. Okay. But what we do is we are creating local seasonal vegetable forward recipes to increase fruit and vegetable consumption, and they're awesome. We do unboxing videos, we do cooking class videos. That's our YouTube channel. We do almost everything online, first because of COVID, and then because of transportation. You can check out the kind of meals that we're preparing with participants. We try to make them kid friendly, easy to make, and we give everybody all the ingredients that they need.
I love that. I love that. And then, do you have like sort of a library of these cooking nutrition videos? Plus, do you also do some live interactive presentations online?
Yeah, we do. So the cooking classes, you can see them on YouTube, but those are most of those are recordings from Zoom. So we do that primarily first. And, we've done a lot of soul searching and surveying around, what times are the best and how to get more people in those rooms. But it really turns out with people with kids and, jobs and transportation issues and everything else that's happening, the easiest thing to do is to be able to give that Zoom meeting a shot and then make it available for people who can't meet it. That all said, this is like one thing that we do. We're also a heavily invested community farm. And so in person, we have cooking classes, we go to the YMCA, we go to elder care, we go all over our own, little, funny rural town to make sure that people right here can get those in-person cooking classes as well.
Joshua, tell us a little bit about the farmer community. So you've got roughly 450 shares, and I know you're looking for a big expansion into 2024, but you supply some from your farm. You've got a couple of other farms. You and I've talked a little bit about the World Farmers group, a super exciting connection that you guys have there. Talk to us a little bit about the farmer community. They're engaged with this project.
Yeah, so I'm sorry to say that if that number is mine, let's see, 250 I may have lied a little bit. We do 500 shares locally, and then we do 300 shares through World Farmers.
Okay.
And honestly, so writ large, like I said, we've got a dual mission, and we want to pay a fair wage to farmers to grow, to do their jobs. We're trying to guarantee markets for as many farms as we can and support the local food system. We have longstanding relationships, but it's also, it's been easy for us to help prop up new farms, small farms, especially with meat. We can do big pre-orders for chicken and pork. And like I said, our pig guy is right down the way on sort of an extension field. And man, I just feel so lucky to be able to work with World Farmers, and I will provide a link when I'm not running my mouth. They are an organization, the Flats Mentorship Program, that houses the business of 300 immigrant and refugee farmers. So those are folks from all over the world. And what they do over the Flats Mentorship Program is they share equipment, they share markets, they get free or cheap access to land. And then we just go in and guarantee their markets for the year. And they provide gorgeous boxes for us and cultural crops that we don't grow ourselves. And then they do all of the aggregation and delivery for that section of the state. So I feel super grateful to be able to funnel some of these funds towards that organization. And as we grow, we certainly are considering working with other sister organizations, other farms that share our values. It is, I don't mean to scare anybody away, but it's quite a lift to do the administrative piece for our members and for our partners in the logistic pieces. So if we partner with organizations that can do the growing, the aggregation, and the delivery for us, and then we can just write them a really fair check for their work, and then just handle the overhead. And like I said, we're doing both worlds. We're the administrators for as far as World Farmers go, and we also run our own small local operation here.
Right. Yeah. So a related question came around. Speaking of logistics, maybe talk to us a little bit about how the delivery mechanism works about getting food from the farms to your, uh, what's kind of the catchment area, the kind of reach from around your
Yeah,
farm to where people are getting food.
absolutely. So for our home routes, we do up and down the 91 corridor. And for folks that aren't as familiar with this part of Massachusetts, it is basically Connecticut to Vermont within the state. And we are doing all of the growing or buying and aggregating right here on the community farm. We have, aging infrastructure as we grow. That is certainly a consideration. We're working on barn updates that will really be critical to our continued growth. And then World Farmers, who frankly has much better aggregation space than we do, it goes all the way across northern Massachusetts, like skirts the Vermont, New Hampshire, Maine border, and then dips down into Brockton Taunton, which is like almost southwest Metro West, like southwest of Boston,
Mm.
opposite side of the Cape.
Yep. So it's a big distribution logistics challenge, it sounds like, with lots of partners involved.
Yeah, well, we do all the routing, and we do all the communication with patients too. So that's part of the burden that we take on.
Yeah.
So yeah, it's been good. And I will shout out, you guys probably all know about this already, but tools like Routific and simple texting just make this all possible.
Yeah.
Besides that, our CRM, our contact resource management system is Salesforce. We have a custom Salesforce module, and it was worth every penny.
Yeah.
Joshua, I've got
Re-
another question. Does your farm operate as like a hub that aggregates food from a number of different farms? I know you said that you're working with World Farms, but are the 500 shares you mentioned coming from one single farm, or do you aggregate from multiple farms?
Yeah, we're doing aggregation. We do buy-in and aggregation from multiple farms. So we've got
Okay.
a buyer on our farm team, and we organize really from a number of small local farms. It's some extra work from time to time, but we get a great product and we stay local. And yeah, go ahead, please.
Yeah, I'm sorry. And then does your organization's a nonprofit, right?
Yes, we're a certified 501c3.
Okay, and so does the program, which I understood you to say is grant funded, does it? Do you feel like it has a good return for the farmers? Is it economically making a contribution to local firms as well as being balancing things out for your nonprofit?
Yeah, we make sure that we're paying top dollar for produce. We can't skimp. It's incredibly important for us that we're both supporting farmers and supporting people who are in access of food. It's incredibly, I know it can be difficult, but I think that playing the long game, we need to be able to support our local agricultural organizations. And what I should say too is that we grow about 300 of those 500 shares. And so, and then slightly less in the winter time, it's just because like I said, our storage isn't ideal. So in the meantime, we're doing more aggregation in those cold months, February through April can be trickier here to get fresh food. So we're doing buy-in from, sister farms that have better storage than we do.
I guess one of the the reason that I'm asking these questions is because the hub that I work with is a fairly young hub, maybe 3 years old, and they are kind of a hybrid model. They have direct to consumer sales, including the workplace wellness program, as well as institutional sales like farm to school and farm to food pantry. And as we're thinking about moving more into this food as medicine, food boxes, there's a couple ways we could run this. We could, like you, take on more of the administration and content development, which is what we're already doing for our workplace wellness. Or we could say, healthcare entity, you guys figure that out, and we're just going to run the food business. And as I'm trying to think about, how to couch this to our executive committee and thinking about going to be more economic viable and more that looking for to bring in revenue to get to that break-even point. We're only minimally grant funded at this point to run some programs. And the ultimate goal is they do want it to be profitable for the farmers, because this is a farmer-owned collective, and it's a business, it's not a nonprofit. So it's just interesting to see how can these models be achieved.
Yeah. I think it's probably worth calling out that we've grown fairly rapidly over the past 4 or 5 years. And there's always sort of as we've gotten bigger, we're not eligible for this, the same small grants, and there's different pools of money that we have to be applying for. It is almost like two distinct businesses. We have the small community farm and the food aggregation, food as medicine operation that work in tandem. And those may need to become legally distinct at some point, but at the moment, it is beneficial for us to maintain nonprofit status for the whole operation. We are heavily subsidizing a lot of the work that we do through grant money and donation solicitation.
Joshua, maybe just keeping a good pace and knowing we've got a lot of folks leaning in here, especially interested in the SNAP conversation. Maybe talk to us a little bit about y'all's experience with that. And I know it's kind of, there are state to state issues, but about how many of your shareholders are in that food insecurity space or would be eligible for SNAP? How much of that is the focus of your program kind of going forward? Tons of questions around all that stuff. So give us a little perspective there.
Yeah, no, that's great. It's just core to our mission. Food access is who we are, and making sure that folks that are experiencing food insecurity, who often have SNAP, but not always, can get a CSA share is really important to us. And that lives back into why we decide to stay a nonprofit. So we were real early adopters, both Just Roots and Massachusetts, in having SNAP be able to be utilized for CSA, and then we also have HIP, which HIP is just spectacular. A lot of different states do it in different ways, but it's an additional benefit. It's a buyback, which I don't love. Don't love working with Conduent to have to do the buyback because it's confusing. But the first X number of dollars every month it's paid with a SNAP card hits HIP first if it's local fruits and vegetables. So, for example, if you're a family of 2, you get $40 a month. And the cool thing is that pretty much any family who has SNAP, because we also utilize a sliding scale under which people who are paying with SNAP can opt to pay at the lowest rate. HIP almost pays for the whole share. So if you're a family of 3 or 4, you're getting $60 a month, and our payment per month for that lowest share is $45. And if you are a larger family, it's like 5+. Your payment is $80 a month, and that'll take care of the whole full share. And that's really what we strive for, and we work with folks a lot to make that work. We have some people who are not paying with SNAP at the lowest tier as well, just because there's lots of people in our community who due to recent change or the benefits cliff or immigration status don't have access to SNAP. And we just try to make sure that we can get food to everybody as much of it.
So a super question is coming up, or not everybody knows. Can maybe explain a little bit what the HIP supplement is for SNAP and how that works?
Absolutely. And I probably rattled off without even defining it, but it's a healthy incentives plan. And it's like the farmers market coupon token program, except it's a buyback program. Effectively, you spend, say you have 40 bucks in HIP and you spend 35 bucks at the farmers market, or as long as the farmers market is a certified vendor, not everybody is yet, and just make it harder. But if you spend $35 on fruits and vegetables with a certified HIP vendor, that comes out of your SNAP card and then it goes right back. It's been excellent. It's been really excellent because it's not that brutal economic choice of I could buy greens, or I could buy something that is cheap and calorie loaded because I know it's going to feed my family for longer. So having an additional, and we talk to people. We're still doing outreach for HIP. When we talk to somebody new, we say, "Oh, you want to pay with SNAP? Do you know you have HIP?" Say, "Hey, your whole CSA will get covered by this program." I also know, talking a lot about HIP here, and I think that you guys do not have it there. So we could talk a bit more about double dollars. Yeah, it's just like that. Absolutely. The cool thing is that the Department of Transitional Assistance that runs the SNAP program in Massachusetts also allows us to schedule for prepay. They don't like it. They don't like it, but they do it because they know it's the only way that they can work with farms. So they allow us to charge within 30 days of the people receiving their share, which is great. It means that we can sign somebody up in March for the June CSA, send that paperwork to the DTA, and the DTA will regularly pull out the benefit before the participant has time to deplete it on other purchases throughout.
And the DTA is your local Massachusetts department for.
Yeah, they're the Department of Transitional Assistance, and they run all SNAP HIP programs with throughout. Right. So and they can be tricky to work with. Sometimes I feel like we're the front car of the roller coaster, but they really are, they do good work, and it's just a matter of getting them to catch up with the needs of small local farming organizations.
Yeah. Well, that's going to be pretty exciting and a pretty powerful leverage point if you can tether the HIP funding to your SNAP recipient. So it sounds like you're missionally trying to grow that way in terms of your shareholder reach.
We do.
So do you have some specific ways of promoting or doing outreach to that community?
Yeah, absolutely. It's all about coalition building. We have to know where people live, who the stakeholders are and community leaders. We have to go to where people are. And at this point, we've been around for a decade and a half, and people know who we are, which is great. But there's always more work to be done, and there's always new communities developing. And so yeah, we work with individual housing developments. We work with childcare organizations, organizations that serve immigrants, community action, youth programs, drop-in centers, food banks. And it's harder. It's absolutely harder to get low income members who might be interested to know about it and sign up consistently. We do a lot of physical flyering. We do a lot of tabling. And then one of the things that we have found that's really, really helpful, I think I've mentioned this before, but man, text messaging, it's just a super potent vehicle. We have got a cheap mass text program called Simple Texting. And we can also, anyway, it is not a total substitute for calls or in-person, handshaking conversation. But it just reminds people who we are, what we do, and when whatever dates coming up are coming up.
Yeah. Yeah. I mean, it sounds like you lean a lot on between your YouTube, your texting, a lot of digital communication. You don't run into problems with that with the audience that you're trying to engage with. They seem to be okay with that.
Yeah, it's really interesting. And like I said, I don't mean to be overselling it. I'm like the guy behind the computer here. But we do a lot of work over the phone. We do a lot of work in person. And really, I think we did 80 different workshops and demonstrations last year. We do everything from putting in community gardens to doing plant-based dye workshops on the farm. Just anything that's food or agricultural adjacent, just to get people there and help mitigate some of the social determinants of health through mitigating social isolation. So that's critical to us. And also, honestly, like I said, we talk to a lot of people a lot of the time, and people don't have time. There's
Right.
a lot of people with multiple kids, don't have great transportation. They want it easy, and they want the lift to be on our side. And we oblige whenever we can. And so, yeah, people have really appreciated it. Rutific, again, I'm just gonna layer on. I was a Commodore kid back in the 80s. So Rutific is just an amazing program, and it will we can program it to send out auto texts. So I dispatch a route, and everybody on that route who can receive text messages gets a message that says your delivery is going to, you can expect it between 3:30 and 4 on Thursday. And then once it's been delivered, they get another text so that people can, make sure that they're home or that somebody's home to receive. And it's just, people feel security around that. And I'll tell you what, I would say about 98% of our participants, at least through our farm to family program for Food is Medicine, do give us cell phone numbers to use. We work with elder care. We work with several folks that, the only way that they're going to pay is by handing the farmer a crumpled up $100 bill directly. So, we run the gamut. But I guess as much as we can, the automation of some of the communication gives us the opportunity to reserve people power for those, really important, on-call conversations that we need to have when they call.
So it sounds like most of the shares are home delivery. Do you use pickup sites or drop sites or aggregation pickup places, or maybe just a little more detail on that?
Absolutely. So, like I said, we kind of have two bases of operation. World Farmers is out in Lancaster, east of us, north of Worcester. And that's a start to finish 100% delivery. When we first started the Farm to Family program, which is our Food is Medicine program with the ACOs, they thought it would probably be at either hospitals or pediatric care centers. And it just, start to change the way that people felt about that space. You come and pick that up. You maybe have an in-person conversation. Maybe there's a little workshop or something that they can do there. But then, 2020 came around, and that was not even an option. Yeah. And so, we can talk to people, because the way that we figured it out, what they needed was to ask. And folks said, yeah, I couldn't do this without delivery, which was decisive enough for us to continue without question at that point, delivery for all our farm to family members. But we also have delivery sites in Greenfield. We do a flexible delivery. So we have 3 different times and dates that you can come and pick up your CSA. One is a mobile market right in front of the Rite Aid and across the street from the community health center, right downtown. And then we do 2 on the farm. One that goes sort of like after the work hours, and another that is on Saturday and just give people plenty of time to pick up. And then for folks that do pick up on the farm, we've got all the things. We've got, playground, we've got a tent and a tarp, and we've got lots of U-Pick. What we really want to try to do is make the farm welcoming, and then just a place where people can kind of come and hang out. And there's a lot of relationships that are forged at the farm, and that's a huge component of our wellness impact.
Yeah, super. And I know it's a little early to get a real good sense of this, but do you get a sense of what kind of return or retention participation year over year you're getting from some of your folks that are in that program?
Yeah, so Food is Medicine, they tell us whether or not they can re-enroll. And they did re-enrollment for a while, and then the 6-month limit on interventions came around, and then now we'll see. But for our home CSA, it tends to be good. We have, what are my darn notes? It was the last survey that we just took. It's a 95-ish% intention to return to the CSA for our home, which feels good. And honestly,
yeah, that's amazing.
We put a lot of work in, really catering to the community. But also I will say that even if people want to, they might have to drop, their an unexpected move, or their benefits change. And especially for our most vulnerable members, we just have to put extra work in to make sure we can maintain them.
Sure. Katie, you had a question?
Yes, I did, Tim. I had a 2-parter, Joshua, just to, there was a question in the chat from Martin about like survey evaluation. I know you were just doing a lot of survey number crunching. And so I was wondering if you could share a little update from your program this year. But prior to that, or after that, my other question was a lot of folks in Kentucky work with a Food is Medicine angle kind of around like pregnant moms, because that's another entity that's going to the doctor a lot. And I was just wondering, like pre-post talking about the surveys, if you could kind of give us the genesis story of why you identified pediatric children as like your kind of target audience. And are you opening that up to like, adults with type 2 diabetes or pregnant moms, or like, what are your takes on like target audiences for these types of initiatives, and like what are the pros and cons of your audience? But pre-post the survey question. Those are my 2-parter.
Yeah, absolutely. So let me take that one on first, and then we can dig into survey data. So yeah, we absolutely have worked with pre-postpartum mothers, and it's hard. Oh man, it's hard because people who are pregnant have a lot of other things on their minds, and while it might be easy to rope somebody into thinking about changing the way that they eat, or joining this new thing once they've had a kid for a little while. When we reached out to, through a specific program, we reached out to pregnant and recently postpartum folks, it was just really tough to get them to, respond, show up, enroll. And so it's important, and you're doing excellent work there, but I have no advice on it because it's not something that we're good at. Now, we've had plenty of regular CSA folks that are parents who have become parents, and we switch them on to delivery so that they have one less thing to think about, and we try to take care of them when they're they've had a new baby in their lives. But as far as a population goes, very, very difficult. And how we came about pediatric patients is primarily ACO led. So, these are kids who are at risk for diabetes, at risk for heart disease, experiencing food insecurity. It's just like very clear to the ACOs that, they need an early intervention for these households. And so that's been their first priority. And recently, Atrius Fallon has expanded the criteria so that adults at risk or experiencing nutrition, food-related illness are also eligible. Does that answer your question? I feel like it was a little bit of a sorry, I wish I knew more.
No, it does answer my question. It's like kind of ACO led, and it was like another target population. And these kids, I guess I'm like sometimes the logistic of like those children do have higher health complications, so they're coming to the doctor regularly too for like the evaluation, because it kind of feeds into the evaluation. Because I feel like the other part of food is medicine that's kind of hard is they have to be returning frequently, right, to get evaluated or.
Yeah, absolutely. So, it's kind of happening. It's happening in a way that's segmented, and I don't love it, but I understand. We don't have access to chart data, so the folks that are aggregating it and looking at it holistically are only on the healthcare side. And I understand why they do that. We're farmers, and we don't need somebody's, complicated health history. But it's when we can get it from them, it's great to get that data in aggregate. So they get our surveying, they get the qualitative data, and they are reporting to Mass Health the chart monitoring as well.
I know one of the questions Katie was pinging toward too was along the lines of data and feedback evaluation, but one of your partners I know is Boston Children's, right?
Yeah.
And maybe just share with the group a little bit some of the story about how you guys made some of those connections with some of those wellness professional communities and how they've kind of worked with you in partnership to help build the program.
It's really good. And I will jump right back into metrics and can also share some later if there's any that we don't hit. But it's like I said, when I first came on, we noticed anecdotally difference in the health and well-being of participants, especially low-income participants after joining the CSA. And so we were able to work with Dr. Seth Berkowitz on quantifying the increase of fruit and vegetable consumption through participation in the CSA. And that data is out there. It's great. But soon after that, we were approached. So it's like people are paying attention to what we're doing here, and what y'all are doing. And so once the ACOs see the quantifiable data on the potentially changing health outcomes, they look at the price tag and they see it as saving money. So Boston Children's Hospital started an arrangement with us where it took a bit to work out, but they negotiated terms and we started serving their patients first. Our first year was 2020 working with them. We've been doing so since, and certainly it feels it's new. And we're, like I said, first car on the roller coaster out here, figuring out how it works. Most of the other interventions in Massachusetts, and nutrition interventions, are either a food card or medically tailored meals.
Yeah.
So we're kind of stand out in that we're a smaller intervention, and also we're providing an intensive, local product for their patients. And so far they've been just awfully pleased with it. And then once you work with one, especially Boston Children's, a real high profile out here, it was real easy to get in working with Mass General Brigham. I said, oh, you're doing this with BCH, we want in too. And then recently with Atrius Fallon, we're not an unknown quantity. We've been doing this for a few years now. Folks are more familiar with the model. And so it's easy enough. Just it takes some doing up front to make sure that we all know what the other needs and to do a bit of negotiation. But yeah.
So
at this
what
point,
are they
easy.
what are they asking you to? Are they like doing a referral or prescription? Are they providing funding? What sort of?
Yeah.
Tell us a little more about that relationship.
Absolutely. So at this point they're providing referrals. And the way that I understand it, in 2025, the flex funding is likely to move to capitation. So that you're getting paid per instance of intervention, and it also the intervention gets its own code and can be prescribed. So things are changing, and we're likely to see that change soon. And I'll tell you, you got to buckle up if you're in here, because there's an awful lot of pivoting
Yeah.
in the programs. But yeah, it is a lot. I'd say it's a lot more. We need to be very responsive, and we really need to have our data straight. Especially when it comes to points of contact and delivery numbers. Everything is managed, like I said, through Salesforce. And for BCH, we're doing weekly reports to them. We just do a whole report out, gigantic spreadsheet that they.
Yeah. So what's reported to them
through.
particularly?
Yeah. So really what they're hoping to see is they get any changes, any address changes, any contact changes.
Oh, okay.
They get all the points of contact. They get, everything that has ever been delivered. We just report out basically everything that we have on the patient every week.
Yeah.
The other ACOs have less, not less rigorous, but less regular reporting. But at this point, we have those reports ready to go. So it's a couple of button clicks for us to get there. And that is just like we certainly invested in those efficiencies.
I'm thinking partly on behalf of some of our other CSA Innovation Network folks that are in different communities around the country, imagining that it could be really useful at some point in time having a follow-up conversation, maybe with some of the people within the communities, like the Boston Children's or some of the other places that are developing these programs, and they're having them communicating to some of the medical people we're working with about the value of programs like that, as we're always looking for ways to beg, borrow, steal, adapt, tweak. So could imagine that could be a really helpful contact later on down the road.
Absolutely.
Yeah.
Just let me know, and I can help try to set it up.
Super. Well, Joshua, we're right up to our time here. People have paraded in with lots of good comments in the chat, really good engagement. I personally want to just really thank you for taking the time to hop on, and huge appreciation for what you're doing there at Just Roots and the impacts that you're having there. And I know you're very much a like-minded fellow with interest in helping farms and helping your communities, and really appreciate all you do.
Absolutely. Thank you so much for having me. I just relish the opportunity to chat with you all and to collaborate. And for that point, I've been talking the whole time and haven't gotten to know you guys. Please just, go ahead, and my email's in the chat. Drop me a line. I'm happy to follow up on any questions we didn't have time for.
Outstanding. Katie, anything else we need to touch base on?
I don't think so. Thank you so much, Joshua. And we hope to do a few more Food is Medicine coffee chats. Joshua, maybe you'll come back for a take two, but just stay tuned for some CSA Innovation Network events coming up. And thanks for joining today.
Great. Thank you all so much.
Awesome.
Take care.
Thanks, everybody. Thanks all. Have a great afternoon.